Hello? Hello? ما ظهر. على الكاميرا. المفروض يكون طيب. كده الصوت ظاهر. الصوت الحين كاميرا ما في. ايوه. Hello? Hello, السلام عليكم.
عليكم السلام دكتور، سامع منك؟
معاي؟
ايوه
معاي؟
عليكم
طيب, بسم الله الرحمن الرحيم. Let us continue on the lectures of tropical diseases. Last time we had 2 lectures on schistosomiasis. Third lecture on the same line, and we hope to finish up the schistosomiasis. Do you hear me now, all of you? You do? You do? Do you hear me? Nobody there?
Yes, we can.
You hear me? I need more voices to say yes, we hear you, so that I can continue.
Yes, we hear you, doctor.
Yes, we
Thank
hear
you.
you.
Okay, thank you very much indeed. Okay, now going to schistosomiasis. You remember, we just highlight some of the important points of the last 2 lectures. This is a trematode, the blood fluke, which lives in blood vessels in a particular place, the vesical tributaries over the bladder in hematobium, over the mesenteric vessels around the colon in Mansonae, and around the small intestine and large bowel in Japonicum, which is Southeast Asian schistosomiasis. You have to remember that the disease is mainly due to inadequate sanitation and lack of potable water or drinking water, safe drinking water. So if you have these 2 in any village, then the chances of schistosomiasis will be less and less, because children goes and wade, swim, and adults will bring the water from the canals. They have to wait, and if they defecate or urinate in the canals, then they have to wash themselves from the water of the canals. And you remember that the water of the canals contain those mollusks.
الفيديو هو ما شغال.
الفيديو ما شغال.
كده شو الكاميرا بتقول لنا الفيديو؟
الكاميرا شغالة هسه؟
Yes.
Can you see me?
Yes.
You hear me now?
Yes.
Okay. All right, so we continue. So the canal waters contain the snails of the two types. Each species of schistosomes have a special snail, Bolinus, truncatus, or Biophilaria. These are two different snails which harbors either the hematobium or the mansonite. I would like you to think beyond what I'm teaching you is why and how that one species will have one snail and the other species has the other snail. There is something which attracts the schistosomes to that particular snail where asexual life continues to secrete cercaria, which goes in normal people or healthy people in their skin. And then the cercaria, which you remember, has a head, a stem, and a tail. And once they get into the skin, the tail and the stem will get out. It becomes schistosomule, which goes in the body from the venous system to the portal system. And in 2 months, they get mature in the portal tract. 2 months in the portal tract. Remember, these 2 months is an approximate of the life within to get maturity in the body, human body. And it is the same 2 months which is needed by the mericidium, which is a hatched egg, to go into the snail and get maturity to cercaria. So it is 2 months here and 2 months there. And when I talk about treatment, there is another 2 months, because if you give treatment, you examine the stools or the stools in 2 months, 2 months time. Okay? Okay? So the transmission is infected person excretes eggs in the canals. The eggs hatches within 2 days. If they don't find a snail, they die. They live in the snail for 2 months. They get into cercaria. Cercaria is the infective form. Cercaria is the infective form. It gets into the body, piercing the skin. Okay, matures 2 months, and then the coupling adult worms, male and female, attaches themselves to the venules and coats themselves, or they coat themselves with human proteins so that they will not be considered as foreign and be discarded by the body. And they live there for 7 years. This is important. These figures are important because for 7 years, this worm will excrete eggs in massive in thousands into either the stools or the urine. So wherever we're talking about control, and here this is important for batch 26, that what you are seeing here is part of the community medicine. Okay, so this is they continue secreting eggs. Okay, and 50% of the eggs secreted only find their way to the outside. Other 50% will remain in the body. And here is the crunch, because this 50% of the eggs which are retained in the body are the cause of pathology. This is very certain, and it is completely exclusively the pathology is caused by the eggs. Why? The eggs exudes lytic lesions, lytic material, and they pierce the walls of the bladder and the colon. And when they are trapped, this material which comes out of the eggs is very antigenic. It invites a lot of reaction, mainly plasma cells, macrophages, lymphocytes, eosinophils, and in the center, you'll find the egg. It's important, very important, that the granuloma, wherever it goes, it makes a space-occupying lesion and then heals by fibrosis. And this is simple. This, if you know your anatomy, then wherever this fibrosis occurs, then you have blockage. And we already dealt with the symptoms of hematopia. And remember that it is not urinary schistosomiasis, it's genitourinary schistosomiasis. Because now we know that the genital part is very important, that has been neglected for a long time. Also, genital schistosomiasis increases the risk for HIV, and this is new information. Okay, urinary schistosomiasis will cause the lesions in the bladder, which is called ulcers, polyps, sandy patches, ureteric blockage for fibrosis, hydroureter, hydronephrosis, and renal failure. In the colon, the ulcers, the polyps, single polyps, or multiple coli, that is multiple polyps in the colon, which simulates the hereditary type of multiple polyposis coli. So on one side, carcinoma of the bladder is a real risk, and here it occurs in young age group, and it is the squamous type, because the normal carcinoma of the bladder is the transition cell carcinoma. Here, because of the metaplasia of the cells, you get squamous cell carcinoma. And it occurs in young age group, and it is very aggressive. And it has been reported extensive from Cairo, this type of carcinoma, due to the hematobium infection. So that is about the general features, the transmission, and when we come to control, please remember this cycle of transmission. It's important to remember and to look into what is new in the control of schistosomiasis. Okay, the other important fact from the previous lectures is that this is a disease of children. If it starts below 5 years, but mainly after 5 years to 15 years, this is the bulk of patients in the field or in the endemic area. So it is, in a way, a blessing, because these are students or pupils who are in the school, so we can target them with treatment. The 65% of all egg excretors in an endemic area are children, and they have the highest rate of intensity of eggs. So this is the source of infection, and children are not easily controllable, so they wade in the canals and they swim there, they wash there, they play there, they urinate there, and they defecate there. So this is the mix. So easily, when we come to control of the disease and prevention of the disease or elimination, we have to bear in mind this epidemiological phenomena of the disease in being children. Later on, after 2025, the disease will become less and less. And when they reach 30, 35, up to 50, 60, it becomes very little among elderly people. Okay, the question is why? Why is this happening? Uh, Reason one is that maybe the heavy exposure of children to the infection will lead to this phenomena. Otherwise, we talk about immunity, and immunity is very important in schistosomiasis. Number one, the antigens of schistosomes passes through the placenta, desensitizing the baby. So when the baby goes out, already has been desensitized by the antigens, schistosome antigen. He has developed antibodies, and the body has known the antigen and can resist the infection. Because of this, people who are born in endemic areas will not have the very acute schistosomiasis known as Katayama reaction, because they have already been exposed to the antigen. In naive population, naive meaning they have not been exposed, naive population, especially visitors from other countries where it is not endemic, like Europe, America, when they come to endemic areas and they contract infection, okay, they get into the very acute form of reaction, which is called Katayama syndrome. And Katayama syndrome, Katayama is an area in Japan, in Hiroshima, been described there, and it is a syndrome which is severe illness, fatigue, fever, sweating, prostration, coughing, and maybe mucoid coughing, and wheezing, and general aches and pains. This is an acute emergency in visitors who come to the area. And it occurs only about 2 months from contracting the infection. And it is said that maybe that this is due to the worm developing within the body and starting ovulating. So, but the reaction is very severe to the extent that we have to give antihistamine and sometimes corticosteroids. Praziquantel or the treatment at that particular time is not in a hurry. It has to be waited till the syndrome settles, the immunological reaction which occurs due to the infection settles, and then praziquantel can be given later to treat the infection. So this is the immunity part. It's a Katayama reaction because these visitors have had no exposure to the antigen, unlike those who are born in the area of schistosomiasis where they have been even exposed during in utero life. So it's then the complication of the schistosomiasis mansoni in Sudan and in by and large Egypt and other areas has been very well studied, and the most important complication of S. mansoni is liver involvement. And the liver and the spleen enlarges in schistosomiasis at 2 stages. Stage 1, early on with the infection, you get spleen and liver enlarged, and these are soft liver, soft spleen. The liver is hardish, but the spleen is what we call soft spleen, and you may even get lymph nodes, not very conspicuous, but you get an acute inflammation. And then these liver and spleen size during the infection can settle and recedes if praziquantel is given in adequate dose. So once the patient is treated, then the liver and spleen disappears. This has to be remembered because now in the later stage, we talk about hepatosplenic schistosomiasis, and here it is due to the portal hypertension, and the spleen does not regress on treatment. So this is periportal fibrosis or portal hypertension that occurs late. So the most important complication of Esmansohnai is what we call periportal fibrosis or Simmers fibrosis. And Arwa, I think I've sent you 3 papers which was published on Simmers fibrosis from Jazeera area for the first time to determine what is the complication, what is the prevalence of the complication of liver fibrosis in an endemic area. And it was found in those papers to be 16%. So 16% of those who are living in an endemic area have a chance, even 16% will develop periportal fibrosis with the consequences of portal hypertension and the difficult situation of varices. So that is, in these papers, have shown that that is 15, and other workers in other areas have also confirmed these findings that it is now reaching 10 to 15, 20% as a complication of Esmansohnai. Also in these papers, there is a very good description of how ultrasound can be very helpful and very useful, okay, in diagnosis of periportal fibrosis. Periportal fibrosis is granuloma, which are deposited in the periportal area. In the portal is the radicals of the portal vein. These are deposited, the eggs are deposited around these portal radicals. They develop into granuloma and then go into fibrosis. Once they go into fibrosis, then they occlude the radicals of the portal tract. And if you occlude the radicals, because it's a vein, it expands backwards. All the blood accumulates, going to the liver, does not find an easy entry into the inferior vena cava, hepatic veins, into the hepatic veins, and then into the main circulation because of the strangulation. So the portal pressure here, with the increase of portal hypertension, meaning that the occlusion is this mechanical obstruction of the portal flow of blood and leading to back pressure. This is important to remember, because then what happens, that the portal tract enlarges, okay, going back, it enlarges the spleen, because this is passive enlargement of the spleen to a very huge level. And what is being closed? The umbilical vein, which has been closed after the umbilical vein, which has been closed, reopens, and you know that the umbilical vein joins the portal vein, the left branch of the portal vein. Okay, it opens around umbilicus. There is an echo. Somebody is playing around. So it opens up in around the umbilicus, giving you dilated veins. So that is what we call caput medusae. Caput, C-A-P-U-T, caput medusae. And there is, if you listen over the umbilicus, you hear a hum, what we call a venous hum. So if you are asked about what are the signs of portal hypertension, it is superficially, it is the caput medusae, which are veins radiating from the umbilicus, okay? And caput medusae is from the Indian head, which carries snakes going outside from the head. And there is a venous hum, because this is increased circulation increase venous circulation. It is, you hear a hum above the umbilicus. And then other features of portal hypertension is huge spleen. You get a large spleen. The portal vein diameter is about 15 millimeter, 7 to 15 millimeters. And in portal hypertension seen by the ultrasound, that is enlarging because the back pressure on the portal vein. And then the portal venous pressure is up to 10 millimeter of mercury. Remember these figures, okay? Portal vein diameter normally is about 15 millimeters. Anything above, then it is being bloated or dilated because of increased pressure, while the venous pressure is up to 10 millimeters of mercury. Above that, it is portal hypertension. Portal hypertension. So the periportal fibrosis, which appears in the liver, we have shown you figures and photos of liver with what we call clay stem pipe. The stem of the pipe, which is clay, which is a brownish color, and these are strands of fibrous tissue cutting the liver or appearing within the liver. You remember that between these bands of fibrous tissue, the liver cells are normal. The liver cells are normal. So what happens in the liver abnormalities is mechanical obstruction of the portal tract or portal flow leading to portal hypertension. The cells are normal. This is why in a classical case, say classical case, because there are mixed cases with hepatitis and HBC viruses, but in the classical case, the serum albumin will be normal, prothrombin will be normal, okay, enzymes will be normal. It is mechanical obstruction. And this is in contrast with cirrhosis, which is the other major cause of portal hypertension. Because in cirrhosis, the are affected and the cells will not produce enough albumin, enough prothrombin, so there will be derangement of the metabolic function of our metabolic tests of the liver. So that is the difference between the two. And if you biopsy the liver, which we used to do before the advent of ultrasound, if we hit a portal tract, then we can get a granular or fibrous tissue seen, and this will clinch the diagnosis. But if the needle goes between two bands of fibrous tissue, then the cells will be normal, and you miss the diagnosis. So this is patchy fibrosis of the liver. You remember that the liver is the largest solid organ of the body, weighing 1.5 kilogram, 1.5. And the affection of the liver is a major problem, And luckily, now we can end, if we end with end stage liver disease, then no speaking. So if you want to chat, please chat outside so that you cannot disturb the rest of the listeners. So it's the liver being 1.5 kilometers and the metabolic house of the body. If it is being affected by like cirrhosis, then that will show on the blood tests, the serum blood tests. Okay, what are the general causes of portal hypertension? The general causes, we can divide it either prehepatic, that is before the portal vein goes into the liver, or intrahepatic, within the liver, or post-hepatic. Okay, the pre-hepatic is when you have a occlusion of the portal tract or the splenic vein, portal vein or splenic vein. You get occlusion. And this can be thrombosis, blood clot, or infected clots, which will block the portal tract. And this happens often in children. I have been presented a case some time ago as a child of 6 years old. He was hit by a ball in his upper abdomen, and that led to damage of the portal tract and thrombosis. He ended up with very severe portal hypertension with bad sequelae. So that is the early one. And in children, you can get thrombosis of the portal vein through infected emboli from, say, appendicitis or whatever in the intestine that goes in the portal tract. So that is pre-hepatic. The intrahepatic is clearly the cirrhosis of the liver or the periportal fibrosis. Post-hepatic is what we call Budd-Chiari syndrome. Budd-Chiari syndrome. So it's B-U-D-D, Chiari, C-H-I-A-R-I, Budd-Chiari syndrome. And here you get portal hypertension, very huge ascites, and liver enlargement. So these are the causes of the periportal fibrosis. Okay, the consequences of periportal fibrosis is obviously and clearly is varices or dilated compensatory anastomosis. If the pressure in the portal vein goes up, naturally the body will try to find side ways to relieve the pressure. And the side ways are those closed anastomosis between the portal tract and the systemic veins. Naturally, there are occlusions, there are aerial channels between the two portal and systemic venous system, but they are closed. One of them is like the umbilical vein, which we have already talked about, okay? And then there are anastomosis which will open up in the lower esophagus and in the stomach. There are anastomosis which occurs in the porta hepatis in the liver, and other in the spleen, around the spleen. All these will give relief to the portal hypertension. And later when we talk about treatment, surgery is mainly, which is not used very common now, the surgery, the aiming at relieving the portal pressure into the systemic circulation. So this is one of the major complications of schistosomiasis, the appearance of varices, which are ballooned tortuous vessels in the lower esophagus and the stomach, or in the lower bowel, like anal sphincters around the external hemorrhoids. But you remember, hemorrhoids are often caused by, in the majority of cases, idiopathic or due to bad colonic hygiene, but it can occur with portal hypertension. So it is important that these varices will be looked at and be treated. Okay. So all this of schistosomiasis, we are now ending up with the major complication of varices. Varices obviously will lead to vomiting of blood, and this vomiting of blood can be very severe. And you lose the patient in one episode of severe vomiting. So then it becomes a case of vomiting of blood. Treatment will be emergency and would be treated as a case in ER with the normal routine for treating hematemesis. The vomiting of blood can be blood vomited, or it can pass down the intestine and appear in the stools as melena. Melena, M-E-A, melena, which is black stools, very tarry black. It's slimy because it contains albumin, and it is extremely offensive. Feces are offensive as it is, but when they contain blood, they are extremely offensive. So the characteristics of melena is three. One, being tarry black. Two, slimy. Three, extremely expensive. And when we come to assess the blood loss, we have to assess the amount vomited and what we think is melena going back into the in the stools. Okay, so the emergency state of hematemesis, first, we treat the patient as a loss of blood. We have to supply the patient or replace the amount of blood which he lost. And if you don't have blood while you are waiting for the cross match, you can give plasma expander, because any severe, sustained, prolonged hypotension may cause a lot of damage to the kidney, leading to renal failure. Or it can cause coma because of deprivation of the brain from the blood supply. So it's an emergency, and once the bleeding stops, then treatment, further long-term treatment can occur, can be instituted. The other causes of hematemesis has to be excluded, and this can be done by endoscopy. And even during hematemesis, then we can do endoscopy as well, because experienced endoscopists can see what is the cause of bleeding. And the causes of bleeding which you may have is the varices, which now in the endemic areas is the commonest cause of hematemesis in endemic areas. Number two, it could be duodenal ulcers. These are the big causes, or gastric ulcer, or carcinoma of the stomach. And sometimes when the blood is a small amount, and at the end of the vomitus, Mallory-Weiss syndrome, which is not an important one, but it's alarming to the patient, but the bleeding here is not very severe. So the main causes is varices, and then the duodenal ulcer, gastric carcinoma. These are the major causes. So whatever the cause is, replace the blood. If it is varices, the varices could occur in the lower esophagus or in the gastric or in the fundus of the stomach, also leading to bleeding. So what is the treatment at that level? Okay, the treatment has been revolutionized in the last few years, and mainly because our physicians are more expert now in using endoscopy. Okay, one feature is that we are now going away from surgery. Okay, and as said earlier, surgery is about relieving the pressure from the portal system into the systemic system. Okay, so we are now going away from surgery. And the treatment could be outlined into medical treatment, okay, endoscopic treatment of banding or sclerotherapy, and a new technique called TIPS. capital T, capital I, capital PS. TIPS, we will come to that. But once you see the patient, we used to apply a tamponade. Tamponade is pressure. We get a tube called Sengstaken tube. Seng, S-E-N, Sengstaken tube, getting into the esophagus, and it has a balloon at the lower level of the esophagus. If you inflate that balloon, it occludes the varices and stops the bleeding. But it has to be removed within 48 hours, and then try if the bleeding has completely stopped or not. Because we will remove it, because if we leave it, it can make sloughing of the veins and cause more bleeding. So within 48 hours, it has to be removed. That's number one. Number two is we can give drugs, octreotide, which will decrease the splanchnic blood flow, okay, the portal system. That is octreotide. Spell it octreotide. Octreotide. Vasopressin is one which is being given intravenously, and vasopressin also will decrease the splanchnic blood flow. These are being used when you don't have other procedures, endoscopic procedures to stop the bleeding. So you have the drug therapy or drug given medication, or the mechanical occlusion of the varices, compressing the varices by Sengstaken tube, tamponade. 3, you can apply endoscopic procedure. In the endoscopic procedure, you go in, you sclerose the vessels, the varices, sclerose it by sclerosing agent. You just inject around the vessels, and then they get sclerosed and hardened and stop the bleeding. Obviously, this does not treat the portal pressure, does not treat the high portal pressure. And then you can get reopening of other vessels. But at least in the acute phase, then this is an option, which is an important option. The other way is to do banding. Banding is like a string. You band, you occlude the vessel from bottom, occlude it, get a band around the vessel and squeeze it, and then that will stop the blood going to the rest of the varices and stop bleeding. So medical treatment, tamponade, endoscopic treatment, which is either sclerosis or banding, okay, and then surgery. Surgery has moved quite a lot from the big surgery to the small, non-invasive shunts. All you are acquiring, all you need to do is a shunt between the portal system, wherever the area of chosen into the systemic. We used to start from porto cave, from the big portal tract, portal vein to the inferior vena cava. This is massive shift of the portal blood into systemic blood, which has a lot of complications, depriving the liver from major source of blood, and go to the liver will not do that. And you have one complication of the big surgery of severe encephalopathy. We tried other methods, which is splenorenal. We get anastomosis, you relieve the pressure from the portal tract through the splenic vein into the renal vein, and this will definitely affect that side of the kidney. So you have to make sure that you have 2 functioning kidney or other functioning kidney before going into it. These are now surgeries which are not used. But newly introduced is TIPS, which is intrajugular portosystemic anastomosis. What will happen is through the jugular vein, okay, we don't open just by a guiding needle, we get a tube inside the jugular vein going through the vena cava and down to the hepatic vein, link the hepatic vein to the portal radicle, and then you get a shunt which will transfer the blood from the portal system into the venous system. And it is called TIPS, which is now used in advanced liver surgery, TIPS, TIPS, and that will relieve the pressure, giving you less varices and less bleeding. The last is liver transplant. If you fail, the patient is vomiting quite a lot, okay, and then you have to go and apply or test the possibility of liver transplant. Luckily, liver transplant started with the idea of taking a whole liver into a recipient. So you need donors who have been brain dead, take the liver and put it in a normal, into a diseased liver, take out the liver, and then get a transplanted liver. It used to be the method, but nowadays we can take part of the liver, the left lobe, put it, and then get connected. And luckily, the liver has the capacity of enlarging and functioning very well. We have a senior ENT surgeon who has had renal transplant very early in the history of transplant of the kidney. He's a Sudanese who went to America, to Mayo Clinic, and he has been transplanted with a whole liver. Luckily, he got a donor, and he lived almost 25 years after that. So it's a method of replacing the liver, just like replacing the kidney. A famous singer, Abdul Halim Hafiz, if you know him, he is an Egyptian singer. Abdul Halim Hafiz had schistosomiasis, and he has periportal fibrosis, and he continues to vomit blood. He was, at the time, medicine was not very advanced in our countries. He went to UK King's College Hospital, and he was treated there, but unfortunately, because of the lack of the advances of today, he died, so it's something. That time, if liver transplant has been there, we could have had a liver replaced. Okay, so that is the what is about the liver. The ultrasound, the role of ultrasound is extremely important in the diagnosis, because you could have, once you have the endoscopy, you have varices, and all we said is the varices could be due to portal hypertension, and you have outlined the different causes of portal hypertension. So now you need to know what is the cause of the portal hypertension. Okay, number one, you should remember what we said earlier, that the sign of portal hypertension is enlarged spleen, and the spleen can be enormously enlarged, and the spleen enlarges from the left hypochondrium down and to the right, maybe reaching up to the right iliac fossa. So it's a huge spleen, and it's a firm spleen. Remember that the spleen to be enlarged has to be 2.5 times enlarged from the normal size. So it has to enlarge 2.5 times to get felt lower in the costal margin. So the spleen could also be enlarged without feeling it, without palpating it, up to 2.5 times. So once the spleen is so huge, then this is a tremendous enlargement of the spleen. Okay, the caput medusae we have already felt, the spleen, caput medusae. Then the liver at that stage is usually shrunken. It's usually shrunken, and clinically you can determine the size of the liver by tidal percussion. Tidal percussion from the upper limit, you go down, and then you judge the span of the liver between the upper level and to the lower level, and usually the liver is shrunken. What about ascites? Ascites, in the cases which we see in the war, often there is ascites. And you remember we said that the liver is normal in function. So why is there an ascites? Okay, ascites is a feature of hypoalbuminemia. Hypoalbuminemia. Portal hypertension will localize the ascites into the peritoneum. Okay, and this localization, by exudation, you can have small ascites. But classically, all the books, when they talk about schistosomiasis, they present a patient who have huge ascites. Why is this happening? Despite the fact we said that albumin is normal, why are the people developing ascites? The reason is, if there is end-stage liver fibrosis, that is to say that the fibrous tissue has replaced a lot of normal cells, then this is what we call end-stage liver fibrosis leading to deranged liver function. That's one explanation. The other explanation, these patients, because of the varices, will receive a lot of blood transfusion, and they may have contracted blood-borne viruses, which are hepatitis B virus and hepatitis C virus. So if they do, then the liver may be affected by these viruses, and you have co-infection of periportal fibrosis with cirrhosis of the liver, and then you will have everything, the full-blown picture of portal hypertension and liver cirrhosis and periportal fibrosis. But the fact remains that if you see a pure periportal fibrosis, there will be no ascites, there will be no gynecomastia, which is a feature of cirrhosis, there will be no spider nevi, which is a gain of cirrhosis, no palmar erythema, which is of cirrhosis. But you may get caput medusae, because caput medusae is not a feature of cirrhosis, it's a feature of portal hypertension. So that is the difference between the two, and I would love to explain this because there is a lot of confusion in books regarding this phenomena of periportal fibrosis. So the ultrasound is very useful. We don't need it to tell us if the spleen is enlarged or not in this case, because the spleen is beyond the left costal margin, but it can tell if there is periportal fibrosis or not. It is the method of choice. Ultrasound is the method of choice to determine if there is periportal fibrosis or not. Number two, it can tell us the portal vein diameter, which should be more than 15 because of the back pressure. It can tell us if there is varices in the porta hepatis. It can tell us if there is a small amount of ascites. It can even tell us if the umbilical vein is open up. So ultrasound is now have revolutionized our understanding of periportal fibrosis. So that is what about the periportal fibrosis and the different ways of dealing and treating with the treating the different parts of or different presentation of complication of portal hypertension. Okay, as far as treatment of pelvic schistosomiasis in hematobium, bladder schistosomiasis. Then the treatment is by drugs, which is praziquantel, and most luckily, the genital part of schistosomiasis usually receives or get better on praziquantel. And this brings us for the last 10 minutes to the treatment and control of schistosomiasis. The licensed drug of today for treatment, control, mass treatment of, and possibly elimination of schistosomiasis is praziquantel. Prazi, P-R-A-Z, praziquantel, Q-U-A-N-T-E-L, praziquantel. This is a drug which comes in tablets, and unfortunately, they don't have a solution, but it comes in an oblong tablet, which is divided into 4 pieces or 4 lines, and the tablet is 600 milligrams, 600 milligrams, and the dose is 40 milligrams per kilogram, 40. So if you have a 60 kilogram person times 40 over 600, then it takes about 4 tablets. And to make it easy in the field where we can treat mass, we have converted the formula from being kilogram weight to per meter of height, because height is easy to do rather than taking a machine which will get rusted and spoiled. So the weighing system will be incorrect. So the height, it's just a pole we use and the mark. And the mark here, it is 2 tablets, here is 3 tablets, here is 4 tablets. You just put it and measure the height of the person and read how many tablets. It's very easy and very convenient. So it is, praziquantel is a drug of choice for all types of schistosomes. All human type of schistosomes are being treated by praziquantel. The tablet is 600 milligrams, I repeat this, and the dose is 40 milligrams per kilogram body weight, or transferred into height by meter. Okay, the drug given by mouse, which is very easy, it's a very safe drug, completely safe drug. It has some side effects in the first 2 days we will deal with. Number 2, it can even be given in pregnancy, and there is evidence that it does not harm the baby. It can be given during lactation. Again, there is evidence that it doesn't harm the baby. And even if pregnancy is there, the benefits of the patient from praziquantel would outweigh any dangers due to the pregnancy. It's small children, because we said this is a disease of children. Then the problem of solution is a problem, but it can be crushed. Because we have cases who are below 5 years. They need to swallow, so we crush them. We put them in a solution, which is sweetened solution, and then can be given to the child to drink. So that is well handicapped. If the patient is praziquantel in a full dose, he may get some side effects. The side effects may be dizziness, and the drug has been developed first as a sedative, when it has been tested in the animals, when it showed that it is antiparasitic, then it was developed later as an anti-schistosomal drug. The humankind is very lucky to have praziquantel for the treatment of schistosomiasis, a disease which used to kill, a disease which had remedies or drugs which are very toxic. But now we are living in an era where the drugs are very easy. So sedation can be one, somnolence, dizziness can be side effects, and then depending on the level of egg load, then side effects are proportional. Abdominal pain, if the high egg load, you can get diarrhea and you can get blood in the stools. A decent amount of blood out in the stools if the egg load is high. They can get urticaria, allergy, and they can get, itching, not very severe, but it can occur, and the patient may feel slightly drowsy and ill. But this is not common. We rarely use drugs to treat these symptoms. They subside by themselves, but if headache occurs, Panadol, urticaria, and itching, then you can use antihistamines, but usually they settle by themselves. So what is the effect of treatment on the parasite? The actual cause of how praziquantel works is not very clear, but we have an idea that it causes calcium channel leak from the worm, from the tegmentum or to the mouth of the worm. Then it loosens the grip of the worm on the vessel, and then it gets loose and then taken away and die elsewhere. So that is one possibility of the effect or the mechanism of praziquantel on the treatment. It is lethal to the adult worm. It has no effect on premature worms. Where do they come from? They come from the skin in schistosomole. You remember we had 2 months for the schistosomole to develop into an adult worm. So what is the practical importance of this phenomena? Being adulticide, killing the adult, but not killing the premature worm. So the importance of that, if you praziquantel today and you kill almost all of the adult worm, in 2 months' time, which is the period of development of premature worms, then you can still have schistosomiasis after 2 months. Not because the praziquantel failed, but because the premature worms which were circulating at the time or after praziquantel was given are now developing and getting new worms. So that should be important. And we have now drugs for this phenomena of premature worms. So praziquantel will have about 80% rate of eliminating schistosomiasis, not 100%. And the worms, after being killed, they still have an ability, or there is still a chance that viable eggs can be excreted in the stools or urine. Where do the eggs come from? These are the eggs which has been released by the worm, but are on the process of getting out. So if you find after treatment today, you get stools or urine with viable eggs. The word viable meaning it's an egg which, when hatched, can give an embryo to the snails. So 6 weeks or up to 2 months, you can allow excretion of viable eggs. These are important when somebody has praziquantel and he hurries up to the laboratory and says, well, examine my stool and you find X, and he comes to you that you have failed in treating him, tell him that these X, which are already embedded in your tissue, are now getting out. Don't worry about it. This is one. The other reason of continuing viable X, because praziquantel will only kill 80% of the worms, then you have about 20%. This is why if you are away from the endemic areas, if you contract schistosomiasis in Jazeera area and then you come into a non-endemic area, then you need another dose in 2 months' time. In 2 months' time to kill the remaining worms, because there is a chance. And usually you give 3 doses. 3 doses, initial one, and then another one in 2 months, and another one in another 2 months. And by that, you would have completed 100% of killing of worms. Okay, what happens? What is the aim? The aim is, number one, to reduce the egg load. Okay, this is where people are living in endemic area. Because if you reduce the egg load, you reduce the morbidity in the patient, and you reduce the chances of getting the water contaminated. So that is aim number one. Number two is when you reduce the whole amount of eggs, then transmission will be interrupted. Okay. 3, praziquantel will reduce quite a lot of the morbidity, as we have said, in the genital, even in the bladder, which can respond very well to praziquantel, and even early on fibrosis. Early, what we call stage 1 fibrosis, can be reversed by praziquantel. So it reduces the morbidity, it reduces the chance of transmission, the patient becomes ill. So that is our aim. But a second aim is to control the disease as a public health problem. So if we give it in an endemic area, every 6 months, if you can afford it, or at least 1 year, one annually, then you continue till you get the schistosomiasis controlled and the level goes down. But you really have also to cater about water supply. If you can apply clean water supply, if you can improve the sanitation, that people will urinate and defecate in proper places of the toilets and not near the canals. To supply these two, you will get a long way to control schistosomiasis. These are not very easy. You have to dig wells, you have to distribute water. And human beings they seek the best. If you provide clean water, they go to it. They don't go to the canals. If you have supply good latrines, and latrines can be just pit latrines in areas where there is schistosomiasis, and pit latrines are 1, 2, 3 meters down in the ground with these slabs, then it can help. So if you apply water supply, clean, potable water supply, drinking water, and sanitation, this is extremely important. The other is education. If you educate people, especially children, not urinate and defecate, that is another way of dealing with it. Molluscicide, that is, if you use niclosamide. Niclosamide is a molluscicide which kills the snails. This can be used, but nowadays we are not using it so much. But there are plants which can eat out, or fish, small fish which can eat the snails and deprive the Marisidia from getting developed. This is some of the areas of control of schistosomiasis, but most of the program are depending, as far as the general public health measures, they are depending on praziquantel. Praziquantel has other therapeutic effects. It is against cystodes like tinea saginata. It's in a smaller dose, 15 milligrams per kilogram body weight. It can treat tinea saginata, and it can also treat tinea solium, but unfortunately, tinea solium is the larval stage of the tinea solium, which causes a lot of neurological symptoms. But Polonorgis sinensis is another tapeworm which can be treated by praziquantel. So that is the praziquantel, which is an important drug nowadays being used. Okay, are there any drugs for the premature worms? The answer is yes, the premature worms. But the method which we are used about giving every 2 months praziquantel, that can help catching the premature worms which develop into worms. We just wait for them to develop adult worms. Since praziquantel is safe, we can then hit again in 2 months and hit again in another 2 months. But if you are interested in killing immature schistosomes, then artemisinin is the drug of choice. Artemisinin, which is artemether or artesunate, these artemether drugs, which are now commonly used for malaria. These are from plants called Artemisia annua. It is Chinese plant, and the drug has been extracted from these plants and used as a very effective anti-malaria. Luckily, when we resisted to chloroquine, we had the Chinese kept this drug for themselves for a very long time, and then when we needed it, it was released and then developed, and the plant is now being grown in different parts of the world, getting artemether. So if you give artemether or artesunate, then you can kill the premature worm. Because artemether is now one of the important drugs for malaria, we don't encourage using artemether for schistosomiasis because of fear of developing resistance to malaria. So we just remain with praziquantel for treatment of schistosomiasis. Okay, spleen enlargement. The big spleen, important hypertension. People in the early days, they used to do operations taking the spleen out. But now it is very clear that the spleen is a vital immunological organ. So if you take the spleen out, then you get infection, more pain, especially pneumococcal infection, and you can get hypersplenism. The big spleen, like what we see in schistosoma portal hypertension, can be seen also in myelofibrosis, like lymphomas, myelofibrosis of the bone marrow, or it can be seen in Kala-Azar, but in Kala-Azar it's a softer spleen. Okay. The third is what we call tropical splenomegaly, which is chronic malaria, and we'll talk about that. So big spleens like portal hypertension spleen can be found in myelofibrosis, Kala-Azar, and tropical splenomegaly, which is due to chronic malaria. So don't take the spleen out, and if the spleen is being traumatized in a road traffic accident and is being taken, patients have to take anti-malarial for life, which is a big undertaking. And they can get infection, with pneumococcal infection, and then that is a big worry, and you have to keep the patients in continuous supervision. There are a few syndromes related to schistosomiasis I want to close with these syndromes. Syndrome 1 is salmonellosis, schistosalmonellosis. It's now clear that Salmonella typhi or Salmonella paratyphi live in the gut of schistosomes, and they can regurgitate these bacteria out in the bloodstream, giving you septicemia of Salmonella or Salmonellosis. This will respond to antibiotics. But you have to treat the carrier, which is the schistosomes themselves, by praziquantel before you treat the salmonellosis by antibiotics. So that's one syndrome. The second syndrome is pulmonary hypertension. Pulmonary hypertension can occur with Manson due to a filtering of the eggs into the into the pulmonary vessels, causing end arthritis, blockage and fibrosis of these arteries, leading to pulmonary hypertension. It does occur, but not very often. If a patient has fever, you have to consider of salmonellosis. So that will cover most of what we learn about schistosomiasis, and we hope to tackle another tropical disease. I hope Batch 26 have joined us, because it is important to think in terms of the examination of community medicine. It's not only the lectures which has been delivered by teachers of schistosomiasis, by teachers of community medicine, but other disciplines which touches on community medicine. And this lecture is an example of how we talk about the patient as a patient in the hospital, and community as a community treatment of public health. And so it's important to integrate all aspects of knowledge, not only taking an exam on community medicine, then I read the 15 lectures of community medicine, that's only the examination. This is not good. You have community medicine, public health in community medicine itself, in tropical medicine, in parasitology, and in bacteriology, and even sociology. This is what we call community medicine. So those who are expecting an exam on community medicine should expect a wider examination on community medicine, encompassing and integrating all knowledge. Don't restrict yourself to what the lectures has been given, okay? And there's always, in any exam, I advise that there should be 10 to 15% of the questions on non-curriculum questions. These are not being taught, so that we can examine who is the good, who is the excellent, and who is not. So with that, I would like to close and wish you a good time into your studies. Thank you very much indeed.